Welcome to Beyond the Flare, a podcast from IFPA created in partnership with Johnson & Johnson. This is a space where voices from across the global psoriatic disease community come together to share experiences, insights, and ways we can shape a healthier future together. I'm your host, Janina Kostokaite, and today we're going to explore why early intervention matters in psoriatic disease and how early care can make a big difference, not just for symptoms, but for everyday lives. And first of all, I would like to invite each of our guests to introduce themselves.
Hello, everyone. Thank you for having me today. My name is Samantha Wood, and I'm from Zimbabwe, and I'm a psoriasis warrior.
My name is Mark Graham. I'm based in the UK, and I'm a Mayor Therapeutic Area Head for Immunology at Johnson.
My name is Ulim Robiec. I'm a professor of dermatology, and I'm working at the University Medical Center Schleswig-Holstein at the Kiel campus. That's in the very north of Germany, nicely located at the Baltic Sea coast. So I'm doing research and clinical work with psoriasis for more than 30 years.
Thank you for your introductions. I feel it's really great to have such a range of perspectives around the table. And I would like to start with the big picture before we get into the specifics. Can you each share why you feel early intervention matters in psoriatic disease?
I feel like early intervention matters in psoriasis because it helps with symptom management. For example, if you get diagnosed early, if the condition is starting, then you are there's a high chance that you can get medication that will help you manage the psoriasis.
And Mark, what's your perspective?
And Samantha said it very well that really when early intervention is there, when treatment starts early, patients are more likely to achieve or lower disease activity, fewer flares, better skin control. And often this can mean slower any potential complications. And not only can this support a better quality of life, lead to patient empowerment, it also might reduce the long-term costs to patients, to society, and also to healthcare systems.
Well, although psoriatic disease is a chronic illness that sometimes stays with the patients for decades, it starts at a time point no one can really determine, mostly by a triggering event. And then this inflammatory immune-mediated cascade starts. So we don't know why this first point is determined and what really the challenging signal for the immune system is to start this inflammation. But we know that when this inflammation becomes more chronic and lasting, that a memory develops in the immune system. And interestingly enough, this memory also develops in the skin. And the longer psoriasis exists, the more sustained is this memory. That means when there is, for example, a triggered episode, psoriasis fades away, but it will come back due to this memory. And coming back to your question about early treatment, there is some first evidence that when we treat as early as possible after this first disease manifestation, we may prevent this memory to establish itself. And if we are able to prevent this memory, there is no imminent relapse whenever a triggering episode is ongoing again, or we can hopefully prevent a disease course that is causing more severe disease.
So you're talking mainly about the slowing disease progression, about memory held in the cells. So how early is early? 5 or 10 years that you are saying?
Well, this is a very interesting and very good question. Now, absolutely not. Early is really early. So as early as possible after first disease manifestation. The earlier the intervention is, the better is the outcome.
You all made it really clear that early intervention matters, but I think actually achieving it, there are two different things. And Mark, I would love to build on that. Could you share what, in your opinion, are those systemic or perhaps educational barriers preventing like early diagnosis of psoriatic disease, particularly in primary care setting?
Certainly, and we know there are several barriers to the early recognition of psoriatic disease in primary care, and there's often a heterogeneous presentation of conditions, and this can mean that diagnosis can be missed or misdiagnosed with other common dermatological conditions. And data in the UK would suggest it can take up to 5 years from presentation to full diagnosis, which is too long, I think we'll all agree. But we know that physicians in primary care often receive very little dermatological training, so don't have the full understanding and appreciation of how conditions such as psoriasis can be a truly systemic disease. And beyond the physicians themselves, beyond primary care, we know that it's often quite a fragmented healthcare system. So individual components of the condition may all be treated separately, and the patient may not be treated as a whole. So meaning this can also delays in the diagnosis. And what we do know is that there are various screening tools available, but these haven't really been fully adopted in primary care. So we know that this is one opportunity, and I think where we need to think about building and enhancing primary care is more applications, screening tools, and also further education to understand the systemic nature of the condition and also how we can drive better outcomes for patients.
And I would like to follow up a bit on this. Do you think it is mainly about the gaps in awareness and education, or those referral pathways themselves are a bit too slow?
I think it's a bit of both, to be perfectly honest. We see the data I've just referenced about the time it takes for diagnosis, but we also know in many countries the time it takes from diagnosis to seeing a specialist in secondary care can often be quite extensive as well. So I don't think there's one challenge in the system. I think there's often areas we could target to try and improve the patient's identification and ultimately help lead to better patient outcomes in the future.
It's a very important perspective, Mark, especially about those missed connections between the symptoms and the need of different specialists addressing that. And Samantha lived through that firsthand. And Uli spoke about the toll of delayed diagnosis, about disease memory in the cells. I would like to hear your own experience. Can you share how those delays or misdiagnosis shape your physical and mental health outcomes?
Thank you for that. So for starters, with this condition, for in instance myself, at first I didn't know what it was. I had never heard of it. So at first people were giving me their own type of remedies. For example, they'll say these are ringworms or it's eczema, etc. So people will just recommend you any medication they know that can heal maybe eczema, for example. So that was it actually took me back in terms of healing, because I used a lot of creams back then, maybe soaps, even tablets, even because I didn't have a proper diagnosis. So then later, when I then got to something that worked for me, it also took time because the flares were bad and the whole body it was. So it actually took time to heal. So it was really a barrier because it took time for me to understand the condition itself, for me to also then explain to other people about the condition.
Was there a specific moment that felt like a turning point for you, that everything finally started to change?
Well, At first, I had lost hope. When the psoriasis started, I didn't know what to do. I went back home and then we went for a visit to the doctor. I was given creams and some tablets. And then I went back to school. But then there was no change on the skin. There was no change. Then I started reading about it. I started Googling about it. And then I later realized that it was psoriasis. So from then, I started to research about it, but there wasn't a lot that I could do other than just researching and reading other people's stories about how they live with it, what they tried, and what worked, what did not. I was serious because at some point I had just given up. I've tried so many things, so many creams that have been prescribed, etc., but they are not working. But then when the change started to come, that was like after, I think, 3 or 4 years after it had started. And then there was a little bit of change. And then I was like, oh, okay, maybe if I just keep on doing this and not eating this and that, then maybe the skin will change. And then after some time, it then started to clear up.
That's really impressive how you actually found those answers yourself. Do you think there are some other barriers that Mark described, or are there other challenges that feel more specific to your country?
Yes, there's also challenges in getting the medication. Here in Zimbabwe, we don't have a lot of options in terms of the medication. So you might get someone saying, try this and that, try this cream. It worked for me. It worked for my daughter or something. Then when you try to find that cream or ointment in Zimbabwe, we do not have. They have like alterations of the creams, but it's not the exact creams. So we really have a challenge of the exact proper medication for this condition.
Thank you, Samantha, for such an honest reflection about the healthcare system in your country. And if we look at a patient, what would be some long-term domino effects that you've seen that psoriatic disease can cause when it's not addressed holistically?
Yeah, we do have limited data to completely answer your question. But what is probably the best example at the moment is the development of psoriatic arthritis. We know that approximately 20 to 25% of patients with psoriatic disease will develop symptomatic arthritis, although from the very beginning, they have already inflamed enthesis. And we have increasing data, and that is really due to the availability of big data from large clinical trial programs that last for many years or from registries, that when we intercept with psoriatic disease from a very early time point, that patients are less likely to develop symptomatic psoriatic arthritis during their lifetime. So when you treat psoriasis of the skin as early as possible, you may prevent psoriatic arthritis. There's also data about the vasculature. We know that large body vessels like the aorta and others and the coronary arteries are inflamed in psoriatic disease. And if we treat early on with effective drugs, we can at least ameliorate this kind of inflammation. For example, prevent the generation of atherosclerotic plaques. And I think this preventive idea of early treatment is the one that is most fascinating at the moment.
And would you agree that a multidisciplinary team is really crucial here? And who would be those key players that need to be part of the collaboration?
Ideally, we should have many colleagues on board. However, in clinical reality, that's absolutely impossible. I trust on the competence of dermatologists. And dermatologists specialized in psoriasis should also be a specialist in psoriatic arthritis. We know that this disease virtually exclusively develops in patients with psoriatic disease. So with a minimum knowledge of psoriatic arthritis, dermatologists can start treating this disease early on. So dermatologists should be in the driving seat, and with the knowledge they have today about psoriatic disease, being the disease of the entire body, they are able to also start with effective treatments early on when the patients first present at their sites where they're working.
And Mark, when we look at the data globally, does it confirm what we are hearing here from both Samantha and Uli, that early diagnosis and intervention can really change long-term outcomes?
I think it's the stories such as what Samantha's given us are the reason why we invest so much money in research and development. I think it's hearing the individual patient stories really drive towards this aspiration of improving patient outcomes. And really the data shows that early intervention can often lead to meaningfully improved outcomes. And by that, early intervention in psoriasis, as an example, can reduce the risk of comorbidities, increase the chance of a positive response to treatment. And there's a so-called window of opportunity, and some of the data in inflammatory diseases such as psoriasis would suggest that this shortened time frame from presentation to treatment or diagnosis to treatment can actually be a real time where you see benefit if you treat. And some of the data suggests that patients who are treated within 2 years can experience significantly better outcomes. And also, early interception in psoriasis can really change the disease trajectory, such as PSA or psoriatic arthritis. And the data shows that if you improve the clinical response, it might reduce the chance of accumulating irreversible joint damage. So yes, I wholeheartedly agree. Early interception of disease, absolutely critical, both at a patient level, healthcare level, and society level.
Samantha, I'm curious from your side, hearing that evidence and from what you mentioned earlier, that it took you more than 3-4 years, how do these delays affect your trust in the entire healthcare system?
This causes more anxiety and stress, because you will be hoping that you get something better from the healthcare team. For example, only a few know about it. So you're then misdiagnosed, which will then affect your long-term healing. And also, it exacerbates psoriasis symptoms. So there's loss of confidence due to the unreliable treatments from the prescriptions you are given, with the misunderstanding of the condition. So there's no trust at all.
And is there anything that you would want all healthcare professionals listening to this to understand about what that period felt like?
If maybe there is like proper education about this condition and certain other conditions, maybe it will help with the person living with the condition so that they get the right care. And also it will help if they also improve in terms of the medication. If there's access to medication, proper medication, different medication.
Yeah, you've all highlighted how education, timing, and I think you mentioned communication, that all play a part. So looking ahead, what do you think needs to change in the system to make sure that those people with psoriatic disease get the right care and at the right time?
First of all, there should be a general and international recognition of psoriasis being psoriatic disease. So it's not a skin disease, it's a systemic disorder. And from the very beginning, when the patient experienced the first red plugs on the skin, it's already known that you have the subclinical inflammation at the bones, which is important, and in some patients also at the major vasculature, as I mentioned, for example, the coronary artery. So keeping this in mind, people should refrain from just doing topical treatments. And so systemic treatment is becoming more and more important for psoriatic disease. The many countries with restricted resources, where, for example, UV and topical are the only or the mainstay of treatment, And we need to change this. And this is something where we all need to work together to lift up the possibility in that in these healthcare systems, systemic treatments may also be available for psoriatic patients.
Mark, could you share your thoughts?
Yes, certainly. Getting the right care for the right people living with psoriatic disease requires a wholesale change. We've heard about comments about educational gaps, referral gaps, diagnostic gaps, but really, for me, there's a few key elements we should focus on. One is looking to see how we can further embed screening tools, particularly just in routine primary care, because we know this is an opportunity to really shorten the time to diagnosis. And not only bringing in new tools, it also involves upskilling physicians. That's education, and education about what is existing now, but also education on the disease. They shouldn't treat psoriasis as just a skin condition. It's really the education of the systemic nature condition. And these so-called multidisciplinary models need rapid expansion, because at the moment, what we can't have is specific parts of psoriatic disease being treated in different areas, meaning the patient doesn't get the holistic treatment.
Thank you, Mark. This is very insightful, really great recommendations, I believe. And Samantha, I think you have already answered to this question, but would you like to add something as a closing remark?
I would also like to add on what needs to be changed. Increasing the number of specialists in certain countries or undeserving areas, and also increasing awareness. Of course, we do social media awarenesses and all like that, but it's not everyone who has access to the social media as well. So maybe if there's more awareness in the healthcare system, if there's awareness of these diseases, it will also help them to understand the condition, and they will know how best to help the other person as well.
Thank you all. I feel in such a short episode, they managed to come up with an actual plan. Thank you all for being so open. I feel it was a very rich conversation. And that brings us to the end of this episode of Beyond the Flare. Once again, I want to say a huge thank you to our guests for sharing their thoughts, perspectives, and experiences, and to you, our listeners, for being part of this global community. Be sure to subscribe so you catch our future conversations. And until then, take good care of yourself and each other.